allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Lots of public and lots of employees. Any open comments, public comments? Before we dive in, I don't see, Ken's not going to be here, I don't think. So,
I don't know.
yeah.
He didn't say, oh, he told you.
Well, he intimated he might not be here, but
Obviously.
he said he would try, so.
Well, thank you all for coming, so we have a quorum.
Yeah. And John Shine is in Hawaii, so I have no feelings for the man whatsoever. Anyway,
Yeah.
as we get settled in here. Bye-bye. So have you had a chance, Shereen and Gerald, to read the minutes of the last meeting
Yes,
and look at the consent agenda?
and have this much of the calendar.
Right, you already signed and Shereen signed. Go ahead and give it back to
Ken
me.
shows up.
No? Okay.
There you go.
Yeah, that way I feel more. Okay, with that,
So move we accept the consent agenda as presented.
okay, moved and seconded to approve the consent agenda. All those in favor?
Aye.
Okay. We're moving right along. Ed's not here tonight?
Ed is ill,
Okay.
so I will give you a financial presentation. Did everybody get the financials that we sent out?
Yes. Did you guys get a chance to look at them?
Would you like to have a paper?
Yeah.
Shereen, would you like to look at one?
Yeah.
I brought two.
There's only 50 pages there, Gerald. You have to memorize them in the next 2 minutes.
What are we gonna do with it?
Okay.
All right, so I am not Ed, but I will try to fill in for. Oops, too fast. Oh, this is going to be a mess. We'll put you all down here.
Okay, that's fine.
Maybe I'll put you over here. So those that don't know, that's the owl, and it follows whoever is speaking. Does everybody know that? Anybody not? Okay. Not everybody knows, so I'm just trying to make sure that you know. So in December, our volume was a little off. Our volume in acute was up over the prior year, but clinic volume was down in part because of Alturas. We have Alturas clinics, so you're not going to see that. As I looked through the other outpatient services, we were a little light in rehab, in part because of our speech therapy and occupational therapy. And we've had some change in personnel, so that impacted us, and you see that in our numbers. Here's Ken Kessler.
Ken, you made it.
Yes.
Mark,
Being late.
this thing goes really tricky. Okay, I'm not going to use it. Okay, patient charges. Essentially, they're at budget. So is that great? We've been above budget in some meetings and below our months and below others, but we're at budget. Just his page down. Revenue deductions. For the month of December, we can continue to have a lot of revenue reductions, as you can see. This mouse is hard. So is the picture. Revenue was $4,216,000, as you can see. Wasn't our lowest, but it wasn't. December is not always amazing as much. See others and other deductions are in line overall. Some a little bit higher, some.
Going forward, our cost audit, we'll adjust these a little bit, or they'll all come in under one number in the future?
It's a good question. I think we're breaking this, Ed has been trying to break this out to give you a little bit more detail and understanding. We look at lots of these adjustments. For example, the adjustments for capitation. So we get paid under capitation method. So capitation, if you may recall, is if we estimate what the total amount we would get paid in a year would be. They establish a number and then divide that by 12, and then that capitation is the amount that we get paid every month. And there are several departments that we are paid by capitation. Mental health is one. Some of the clinic services are another. And then this adjustment is based on the difference between what we charge for that service and what we get paid through that capitation. Now, in a lot of the capitation, where it is for Medicaid population under the CCO, when we do have our cost report finished, and that was filed, so that you know this, just a couple of days ago, it had to be filed before the 31st of January, and it was filed 31st of January. It was originally due November 30, but they got a 60-day extension. And in that adjustment will be, the state will then cover our costs. And we won't make a specific adjustment between capitation payment and our charges for this, but it will in our costs. So it will always have a lower amount of what we get paid versus what we charge. So that's one, while you see that detail, so it is a consistent issue. Questions? Collections. We're kind of on a downward trend in collections. We're not collecting quite as much as we'd like. So we have several different companies that are offering us different types of solutions. We're looking at those. We're not collecting as much as we should. It's easy to say that lots of other organizations are suffering the same thing, but we have to solve our own problem.
So what's the timeline? How many folks are we having looking at it in a month or 2 months before they might come online, and then?
There are several different companies that have given us proposals of different ways of slicing the pie that they would want to look at. Some are saying we want to look at it after 60 days. Some are saying we'd like to look at the old claims. Some are saying we would like to provide you additional detail, Cerner as an example, on how we can manage our workflow. So there's a variety of different ways that people are offering solutions. It takes a little bit of time to sort through. Because in each case, they either take a percentage or they charge a pre-bill. In most cases, they take a percentage of what they cover. So if we can improve our processes and do a better job of collecting that percentage, can become very expensive. So we want to improve our processes more than pay another company to do what we should be doing. Okay. Days cash on hand, we're at 53 for the month of December. Not our best month, but and we're a long way from being at the 90 that we want to be because of our position with the bank, an agreement with the bank. Keep in mind, most critical access hospitals in the country are in the 20s and 30s. So still a strong position, just not where we want to be. Now, there are some that have enormous amounts of cash. They sit on a couple years' worth of days cash on hand.
We should learn from that.
Well, those facilities often don't have much in the way of a facility because they've already paid off and their facility is paid for, so they're just banking the cash. We're not doing it. Okay, so our, for the month of December, we had net revenue of $4,216,000. We had expenses of $3,244,000 with revenue deductions of $1,134,000, resulting in a loss of $162,000 at the bottom of the number at the bottom right. You can see sort of how the trends have been working. Not where we want to be, but it is where we are. So when we look at year-to-date, you can see the bottom number in the lower right-hand corner, we are $20,000 off of our plan, our budget.
Amazing that quick, Charlie.
Well, we've had some good, positive things that have impacted us. One was the $1,100,000 that we got back from the CCO as part of our cost sharing and the profitability of the CCO. We got $500,000 from the state to help us with long-term care. So those have been positive impacts for us. We also made a concerted effort to try to do without travelers. That was an extraordinarily large expense. When we look at contract labor, that isn't just the nurse travelers that a lot of people think of. That includes lots of different contract workers. Some are, for example, the rehab therapists that we bring here. We've been doing this for years, and many have, once they get here with Amron's arm twisting, have been able to convince them to stay. So that has made a big difference. A lot of the travelers in other departments, sometimes we can convince them to stay, and they find out how great it is. Sometimes they just move along. We also have physicians that we use, different types of contracts that are in that component. So it isn't just what many think of as contract traveling nurses. Now, we were able to eliminate many, almost all, in both acute and in long-term care. Then, because of illnesses and other factors, we've had to bring back some. The cost of those travelers has gone down a significant amount, not as much as we'd like, but we keep in mind that the reason we have travelers, we've had travelers forever in healthcare, sort of like gig workers. When somebody gets sick, we need somebody on a short-term basis, that's what we call them traveler, or some other reason that we need, we're in between. You may recall in radiology, one of our very important MRI positions left, and we were for quite some time without an MRI tech. That impacted our business. We had to bring in a traveler so we could find someone. So it's those kind of things. But when the cost is as high as it had been during COVID, it's unsustainable. Now, it's going to start inching up, and you see that. But we are, I think the fact that you see many of our department managers here, an indication that everybody is concerned about our costs, and everybody wants to see a bottom line bigger than what we have. So we're all working, and everybody's doing their best. Any questions on this? Monthly expenses were, as you can see, well, I can't hold it. Net margin last. Balance sheet. It explains the fact that we have not as much restricted cash as we'd like, but it isn't that far. Our current assets aren't that far month to month different. So it stays very consistent. Any questions? Nope. The next thing that we need to do, I believe I sent out to you, or any other questions on the finances? Okay. This is the month that we get to adopt our budget calendar. So I think I've sent to everyone a copy of the budget calendar. If not, it's pretty straightforward. It is virtually identical to what we did in 2012 and every year.
And it's controlled by law anyway.
It is. But we do need to adopt it. So I would ask that you approve the recommended budget calendar so that we meet the required approved budget by July 1st.
Any discussion? No? Straightforward. Do I hear a motion?
So moved.
Okay. Okay, moved and seconded to adopt the 2023-24 budget calendar as required by law. All those in favor?
Aye.
Passes unanimously.
Thank you.
You bet. Now we get to Loose Lake.
Okay, Goose Lake. Census has been very stable, so we've had, the houses have been staying virtually full, certainly in the month of December. You see that when you look at our revenue. The difference between December and November and October, for that matter, are
Particularly now.
yeah, it is very consistent. We don't have one of the houses open. We closed that when our census dropped, and the principal reason was the cost of travelers. We did not have enough CNAs, enough nurses to be able to handle, mostly CNAs, to handle staffing for the second house. We are working diligently to get that house open. Big part that we're excited about is the CNA class that we have that is ongoing right now. It should finish up the end of February, if I have it correctly. And a little stumble when some of our staff has some illness. And when that happens, and we rely, we're not a deep bench organization. So if one person gets sick or two people get sick, it affects us dramatically. So, but Tori and Nikki figured out a way to find the staff that we needed to keep our RN program going and our CNA class going. So Nikki is working with all of our staff. Of course, when we closed one of the houses, it was a fine opportunity to do repairs that hadn't been done. And so that house is in the process of being fixed back up. There are things, naturally we do things like rob Peter to pay Paul, so we used one piece of equipment and took it from one place and put it in another. Now we got to get Paul paid back, or Peter. So we're working on that, and our goal is maybe in April. Is that about right, Nikki?
End of March, beginning of April is my hope. Yep.
So that's kind of our target, and we've got everybody working toward it.
I know it's a pretty good swing in revenue reductions. We had a positive one last month, and now 22 was negative this month. It's kind of a bookkeeping catch-up, or?
That's a good question. I don't have the answer to it. I will get an answer for you.
Okay. Okay, any other questions?
Okay. Then, always a great one to end off on. Our medical supply company continues to do very well. They had a little bit of a hiccup as we were purchasing some supplies. And that's in part because of how some of the, if you may recall, there was a recall on some of the oxygen supplied masks and support material. So Alan had made adjustments for it. This was, what was it, 2 years ago? Or a year ago?
About 18 months ago, yes, sir.
18 months ago. And Alan had really worked fast to replace the patients that were on that recall with those that weren't. It got resolved. We had to pick up some additions, so that's why we have a little higher cost. But otherwise, it continues to be a very profitable little business.
Yep.
Questions?
No, just a comment. I'd like to get with Alan, maybe tomorrow sometime, just to see how we can get the VA to be a little more receptive to contract services, a little more than what they do.
When you have the ability to convince the Veterans Administration to
I'll
do
go
what
through-
makes sense for
I'll go
their...
through a congressional delegation first.
I wish you all the best of luck.
If you don't try, you don't get there.
That's absolutely true. And any help we can get to get the Veterans Administration to agree to provide services, to allow us to provide service and get paid for it. It's one thing for us to provide the service, just not getting paid is not fun. But,
No guarantees, but again, if you don't try, you don't get it.
absolutely. Any other questions on finances? If not, let's see if I can get out of this. Can you close this out? There we go, just hit the right click. And show. And close that. Go back to the agenda. Dr. Graham is not here tonight because at our meeting in December, they did not have a quorum, so they didn't approve any credentialing or privilege requests.
So none tonight.
None today.
Okay.
So we're fine.
Okay. Now we're up to the nursing report. Tori, you're on.
Thank you. Staffing for nursing, we are stretched thin right now with medical leave and light duty employees. I've currently got actually 6 employees out on either light duty or medical leave. I'm anticipating we should have them all back in the fold by April 1st, so fingers crossed there. I did get one resignation. I have a nurse relocating to the Bend area. But we've got a great CNA applicant and looking for some RN applicants out there, and recruiting's been working really hard on that, so that's been helpful. Meanwhile, we do have our CNA students and our RN students out on the floor on acute, practicing their clinical skills and gearing up for graduation for the CNAs and getting their licenses. And then the RNs are in their second term of a 4-term nursing program, so.
Okay, and that program's
Yeah.
going well now?
It is going well now, yes.
Okay.
Tori, help me again with the number we have in the CNA class.
4 right now, and they're all doing very well.
Thank you.
Yep.
Mm-hmm.
Other than that, we're working on some quality measures, particularly trying to improve our
Documentation to help boost our ability to charge accurately and fruitfully.
Always always a problem, yeah.
So that's our main focus right now.
Okay.
Any questions? No?
Okay.
Thank you.
Thank you very much. Okay. We have the O&A contract.
So, we do have in front of you, and I think I sent a copy of the red line version. Hard to read, but it gives a little bit of a flavor of the changes, so that you have a sense of it. Even as of this afternoon, there are still some changes that need to be made to the agreement that were not, what was printed is not what we had agreed to.
So what did they vote on?
This agreement.
Okay.
And so what we need to do is ratify this agreement. And the changes that as of right now, need to be made, with the exception of one language issue. All the others are effectively typographical issues. They are not substantive. There's one little paragraph that, while we agreed to the changes during the discussions and the negotiations, and it was agreed at the table by both sides, the document doesn't reflect that. So we just need to make sure that that's addressed before it's brought to be signed. So I would recommend that the board ratify the agreement. We will get the fine details sorted.
Discussion. Ratify what I read it the other day that you sent out to us.
That is this document, yes. And if anybody would like to see it, I'm happy to share it with you.
Like no changes since then.
Okay. Got it.
So move that we ratify.
Second. Moved and seconded to ratify the O&A contract as presented. All those in favor?
Aye.
Okay.
Thank you. Thank you.
You bet. Department reports, great big empty here, but what do? I start with Shirley and then work around the table?
Or anyone that would, we have many
We've
departments
got
here.
Steve back there, I mean, we've got all,
Everyone wanted to be present to, I guess, to, well, sure, let Shirley talk.
Oh, I mean, I guess one of my first questions would be moving forward from a public standpoint, what would you like to be reported from Human Resources, from my department? I can give you, how many people we're bringing in and things like that, but I want it to be meaningful, and I want to make sure it's something that, as public service, what would you like to hear and see? So I just,
I'm kind of a statistic type guy sometimes and looking at.
Sometimes, all the time.
Well, looking at turnover, I'd like to see turnover start to go down and a little stability. As you go through the hiring process, I would like to, I know there's always going to be turnover, but, just seeing it quantified so that, normally you would take a look at another hospital and say, yeah, turnover's 20-30% a year. How do we compare and are we doing better? And hopefully, we always try to do better, but we're always going to have the turnover. But I'd like to look at that ratio
okay.
as it goes forward.
Perfect.
And just, when you do hire somebody new, maybe drag them in here and introduce us. And,
No, I mean, we can do presentation, like our new hires, we do it in our Gazette and things like that, but, again, I want it to be meaningful. So I want to make sure that I present what you guys like. So we updated our chrono system because it was not doing what we needed it to do to push out people. I mentioned that the last time. So we have turned on Applicant Pro, and on 117, we've received 45 candidates. We have 3 providers that are currently in the hopper. Providers.
to hire.
Yes, like we're vetting them. So we have 3 right now. We have 9 people, we've hired 9 people, 1 grants manager, a phlebotomist, 2 EMTs, 1 that's PRN and 1's full-time, a paramedic, 2 EBS, and 2 billers since the last update. So we're definitely getting more traction, and as we spoke last time, we're marketing ourselves better, and we're, kind of throwing the net out further. So we just want to, I'm happy to give you those type of updates. We're also just, even from a provider process, I'm working with all the department heads to create a provider orientation and onboarding that's definitely more robust and meaningful. So from a training perspective and having, everyone touch it. So that's in process. My goal is to have that launched by March. So it's a very collective, concerted effort.
Okay, and we're getting closer to full employment here, like in the business office and.
We're getting there. I mean, we've
RNs
been really rigorous, so we're working with different programs and reaching out to different technical schools and things like that and building those relationships. So I feel, my team can let us know, but there's traction and we're getting a lot more. Stephen, how many informatics nurses have you had?
As far as how many over the period of Years?
Yeah,
Oh, 3?
yeah.
I mean, that have come and gone. Yeah.
And so in just the month, how many applications? We're starting to see a little bit more?
Yeah, actually, we had 2 good interviews, 1 withdrawn, we got one coming up, so I'm hopeful. So,
So we're definitely getting the word out and getting more visibility.
Good.
So that's for my part, and I will be happy. Is there anything else you guys would like to see or hear from HR?
Actually, when we hear from HR, we just want to hear full employment and everybody's happy. That's what we
I'm getting there. I promise, it'll be there soon.
But that would come in, back to the turnover, when people are always looking for need to move, or, family, whatever. If you identify just those few that are on the borderline, find out their rationale so we can work with them to retain them.
Yeah, we're doing exit interviews for the ones that we actually can talk to, so that's definitely part of it. So I will be happy to bring more information for you guys.
You're welcome. Lisa, you're up.
I'm up. So as far as the clinic, you can imagine how excited I am to hear that we have some providers on the line. Our numbers of patients being seen won't increase until we get that. So as I started last month, I provided you with some statistics from the clinic as far as our EO-CCO placement. In January, we had 222 patients that we needed to place from that insurance. We're down to 143 this month. Other insurances needing placed, we had 368 in January, we're down to 320. Eligible to request care from Alturas, we're estimating about 200 patients need our care from down there that haven't established in MODOC. So the totals are 790 for for January, and we're down to 663 in February. So we're making progress. As far as patient panels, Erin is carrying a panel of 786 in February, an increase of 40 patients. Roseanne has 680, an increase of 22. Dr. Hussey has 658, an increase of 9. Dr. Gallagher has 606 with an increase of 11. Dr. Chen has 403, an increase of 4. Tiffany saw 24 so far in February, 213 in January. So we have a total patient caseload in February of 3,133 over 3,056. So that's an increase of 77. So we are making progress. They're taking on more patients, but it's hard on them. They just can't sustain that for very long. They're doing the best they can. Our MAs are working hard, front desk, everyone. And the best news is our rural healthcare survey, which began in August, has finally been put to bed, and we passed. So after all the deficiencies, the gal who came in to inspect us had a lot on her plate, so that pushed the date back. But ultimately, we addressed all those deficiencies, updated our policies and procedures, and are moving forward.
Okay. So all Shirley has to do is get us a couple more providers, right?
That's right.
Okay.
I'll take her to dinner if she doesn't.
Just to refresh me, because I was thinking in two different ways. How many of our citizens out there don't have been assigned a provider?
So right now, we have 143 EO-CCO patients, that's Medicare patients. Other insurances are 320. Our Alturas estimate is 200, so 663 patients. And that's down from 790 in January.
Right, yeah.
Okay, thanks.
You're welcome.
Lisa, the Friday clinic, we are still able to keep that open, staffed? I know that at different times they were unable to staff the Friday
The walk-in clinic?
walk-in.
That is dependent on our staff that's out. So if Tiffany doesn't work on Friday, she works Monday through Thursday and takes care of walk-in. On Friday, it's typically Erin Stewart, but she is on vacation, so we'll have Roseanne tomorrow doing half of a day of walk-ins. So we try to provide some if we can't provide the entire day. And I am still hopeful that a Saturday walk-in can be scheduled again once we get more providers on board.
Thank you.
You're welcome.
Sean, you have something to say?
Yes, sir. As the board's aware, we were awarded $98,000 this last year from FEMA to conduct security upgrades. We got the final approval and have begun purchasing the items from that grant. And myself and Stephen and Justin Westcott are currently pursuing the same grant for the fiscal year 2023 to do IT infrastructure upgrades as well as security for the new public health location. Also, I understood that we had some compliance questions regarding the board, one of which was the non-disclosure agreement. Those will be signed again by the board members in July at the beginning of the fiscal year. I've also provided you with the small version of the SDAO board members handbook. It covers most of the frequently asked questions by board members, just as a refresher. That's all I got for you, sir.
Okay. Questions? Gerald, what's on page 4 there? Paragraph 3, item I.
Got a picture of no, there's no picture, so I can't do that.
No pictures. Okay. Vicki, do you have a report for us, or?
So, yeah, we, like Charlie said, we've been pretty stable with both the assisted living and the one long-term care house that we have open with full census of 12 and 12. We do have waiting lists for both houses. And obviously, it's to minimize cost on Tori's side. Anybody who is in acute, they take priority if they need to come to me instead of taking on the somebody outside of the community. I always want to base the decision on who needs the safety the most. If somebody's already in a safe place, they can wait a little bit longer. Unfortunately, I have to make those decisions. So my plan is still at the end of March, beginning of April, I'm hoping to open that second house again. Between some shifting of residents that really need to come from assisted living into long-term care, and then the waiting lists that we have, I'm pretty confident that it will take maybe 2 weeks to fill that house. I have a pretty good plan because the way the staffing ratios are in Oregon, if I have one resident in one house, I still have to staff 2 CNAs and a CMA or a nurse or back and forth. And that's just not cost effective.
Particularly if you have to get a traveler in.
Well, most of my travelers, if I need any, are gonna have to be CNAs.
Okay.
Nurses I'm sitting okay with right now. I have one of my traveling RNs, her contract is up in April, and she's planning on signing on long-term. She loves it here.
Good.
And loves our team, so she's already been asking me if I want to keep her. And I love her, so absolutely we're keeping her. And so I've been really trying to work with our traveling nurses and go, hey, we're awesome, you know, it's a great team. And so, but when we go to fill that house to minimize the increase of the staffing, it's really going to be an all hands on deck. So it's going to be me, my current case manager, my assistant who's currently an LPN. My plan is that we're each going to probably take an admission a day. So theoretically, I can admit 3 people in one day. And then the next day, I can do another 3 admissions. So hopefully, that's my plan. You know, things don't always go as planned, but that's my ideal plan. Because I want to minimize the cost of having to staff 2 CNAs for 1 resident. It's just not, it's not.
Cost effective.
It's not feasible,
Right.
and so when we get rolling, it's gonna roll really fast, so, but we'll get there. I have full confidence in my team, they're very supportive.
And the need is out there, so the patient's need is
Absolutely.
primary, so.
Yep, absolutely. So, like I said, between my waiting list for long-term care and the waiting list for assisted living, there's probably a total of 10 to 12 people
Okay.
on that list. So, and then, with as far as staffing goes, if we need to like decrease on a swing bed, we're perfectly capable to provide the same skilled care. Just financially in a swing bed, we get paid, reimbursed better than in a long-term care facility. So ideally, they stay in a swing bed, but if they can't, we can take them over and provide a lot of the same services. So I have great plans. Let's just hope they work.
Good. Well, sounds very positive. This is good.
So I'm excited. Like I said, it's going to move and it's going to move fast. So.
Thank you. Any questions? No questions. Amron, you're up at the chief table here.
Okay, I'll give you just a kind of snapshot, and if you have any follow-up questions at the end, we'll go there. As Charlie alluded to earlier, we had more staff turnover than we have for probably about 5 years, but we had 2 occupational therapists leave at the same time. You kind of wondered a little bit of why. So I'll give you, at least in my department, one had growing kids that wanted to be closer to grandpa and grandma on the East Coast. And the other we always knew was kind of a stepping stone place for her. She had her first job out of school, so that wasn't too much of a surprise. We also lost our sole speech therapist, which has been a big hit for our department. And with her, it was just flexibility, work-life balance type stuff. We weren't quite able to meet, what her needs were. So yeah, that's what that looks like. I have had several interviews for occupational therapy candidates. I'm hopeful. This is the time of year a lot of new graduates start looking. So hopefully we can have 1, if not 2 of those stick. It's a little bit difficult with new grads because a lot of them are talking about, mentorships, and when they're coming out of school, being kind of the sole person in their field. We have other physical therapists, but we think a little bit differently. So that's been a little bit challenging to talk folks through that with that. On that end, Charlie did mention that our numbers were not great in December, and that was kind of a trifecta of things, the staffing issues, and then also not having, I don't think we fully appreciated our swing bed program and not having those staffing on there to have as many residents and patients down there. That affects our productivity dramatically, honestly. So those 3 things really made a difference with our bottom line. I will say I just did the numbers for January, and they look really good. They're back to what we expect them to look like, even without speech therapy numbers for most of January. So we're hopeful. We started this, something you may or may not know. We did bring on a full-time, they're not full-time, but they're temp employees, but they're doing 40 hours over the weekend, so they're seeing patients down in the hospital Friday, Saturday, Sunday, and Monday, and the numbers on those look really good. They're being just as productive as our weekday providers. Hopefully we can staff those permanently. It's kind of a trial thing. We've done it a little bit before, and we wanted to continue doing it, but I wasn't able to find staffing, so we've gone back to our old way, which is having our weekday people sort of rotate through providing care on the weekends. Certainly we get a lot better numbers with having somebody dedicated to that. So, yeah, I think that's kind of my department in a snapshot. Any questions you guys have for me?
No? As long as, we're doing the patients, providing the care, that's the primary thing. And then secondarily, the money should follow. But
Right.
Primarily, we want to be taking care of those patients.
Yeah, my biggest concerns there obviously are not being able to provide speech and occupational therapy. The biggest hit we take there as far as providing care is with our pediatric population. They see a lot of our autism spectrum type folks, developmental delay, as well as our patients down in the hospital. I think the biggest risk we have there is like a stroke or something like that would, without a speech therapist, that makes things pretty challenging for us. So we're sort of shaking all the trees we can to find one. But so far, I haven't had much interest, even with using headhunters and Shirley and calling everybody I know.
Everybody keeps looking at Shirley, I don't know.
Shirley's ultimately responsible. No, we're all doing,
Thank you, Amron. Yes, I am.
we're all doing the best we can. So.
No.
Not just responsible, but the doer.
Yes. I tell them every day I don't have one.
Okay.
Yes.
Yeah, she gets tired of me asking, so.
You have her on speed dial, right? 888?
I walk by her office.
Okay, now I'm seeing everybody back there, I've been asking for reports from every department. Are you, Steve and?
Yeah, I can talk a little bit.
Okay.
Well, everybody's trying to make money, I'm trying to spend it, So, I've done an extensive analysis on our network, and we have a pretty aging infrastructure on our Wi-Fi infrastructure, including our switches and our Wi-Fi. And, kind of to segue what Sean was saying with getting some of the grants that were coming through. I mean, we're trying to get, two separate $150,000 grants up to $300,000. The need that I've identified is $350,000 that I need to upgrade all of the infrastructure, including a lot of the aging switches that are currently unsupported and are at end of life, meaning that they can't get any security updates, no feature updates. They're vulnerable to, it's actually probably and arguably the biggest cybersecurity risk to the hospital is the aging infrastructure. So with that said, I'm really hopeful we'll get some of this grant money, but that leaves me with, that's a year out. And so right now, I'm trying to get spend right now $48,000, at least start the ball rolling to get some of the infrastructure upgraded over at our CUP or MDF on the tower over here, as far as the admin closet over there too. Those are the two that we've identified as probably the biggest priorities. So we try to prioritize all of our 9 data closets throughout the hospital to have aging infrastructure on those two. So with the $350,000 that we've identified, I'm hoping $300,000 is paid for by the grant, but for right now, I really need to spend $48,000. So just a heads up for you guys. You might see that, I'm not sure, but it's something that we're definitely going to be needing. The lead time to order some of this equipment is horrendous. Coming from overseas and the equipment is just taking quite a long time. As of 3 months ago, it was taking a year, and it's slowly dwindling down now. So it's like, by the time if we got it approved now, it would be, quite a few months before we actually got the equipment and started implementing it. So the longer we wait, the more vulnerable we are. So that's something I'm concerned about as the information security officer for the hospital, but that's something that I think the board should be aware of. So
As you make these changes, does it cause Tori to tear her hair out as
yeah, right.
stuff goes down?
Yeah, we have a lot of our technology that's reliant on the Wi-Fi infrastructure. The patient cardiac monitoring systems, the nurse call systems, our workstation on wheels, so plenty of equipment that are reliant on it. So I think it's an important investment in order to make sure we're keeping the lights on per se at the hospital. So, yeah.
What funding sources are you pursuing? What agencies or?
Yeah, no, actually, I started looking into, at the request of Ed at some point, looking at financial companies that could give us, loan programs, and I looked at 2 of them, and they gave us different quotes in different terms. So if we give you up to $350,000 or maybe, X amount for whatever projects we have, they would use certain terms for the payback on the loans. It was decided by administration that they want to do this piecemeal going out and then try to get some grants too that we're trying to work on as well. So I think at this point we don't want to finance. We'd rather try to finance or pay for what we have as we go, like the $48,000 I'm identifying now, and try to get the rest through grants as much as we can.
Yeah, I was just curious, what agencies provide those
Well,
type of grants?
Yeah, as far as the agencies, what's the agency called? It's the FEMA?
For the $300,000 grant, it's the FEMA Nonprofit Security Grant.
Yeah,
The same one we got, the $98,000 from last year.
yeah. So, and then, we're trying to get as creative as we can with regard to financing, but, we're really trying to go down the grant route if we can. And I'm just concerned about the timeline. I want to get some of this stuff rolling on and approved if I can moving forward, so.
Part of the
The security of it is
process, yeah.
essential.
What was that, I'm sorry?
The security is essential.
I think, I would not argue with that.
We wouldn't expect you to.
Right.
What do you mean?
Yeah, yeah.
Tara, do you have anything for us? Dietary, everything okay?
We're doing good. We're fully staffed. You like statistics, so let me give you some numbers. I just did our meal counts for January, and we served around 6,500 meals. And we kind of run between 5,000 and 7,000, so January was a busy month for us. Let's see. I think the last time that I seen you guys was at a med staff meeting, and I did a presentation on the malnutrition screening, so that's been going well. I've been diagnosing maybe 1 to 3 patients with either moderate to severe malnourishment per week, and the doctors have been really receptive to adding that to their diagnoses, so we're doing well with that. I think, Dawn, you'd asked me about follow-up after they go home.
Right.
I don't have anything in place for that yet. I know we try to see what's your plan when you go home. Make sure, especially with swing vet patients, like how are you going to get your foods? Is anybody helping you? Things like that. But after they've gone home, we don't have anything in place yet. So it's still in the back of my mind. If anybody has any suggestions for that, I'm definitely open to it. As far as needs for our department, we did just purchase a range unit with 2 ovens. It was 15 years old. Maintenance had been working on it over and over and over again, and finally this last time that they had to work on it, we were told that this is probably the last time we're going to be able to order parts. And then unfortunately it happened right during the middle of serving lunch, that we weren't able to use our range because of an electrical issue. And we kind of got the big realization that, oh no, we can't boil water for noodles, we're having spaghetti today. It's a big piece of equipment that we need in order to operate. So we've got that ordered. It should be, I think they said it would ship on the 7th, and then maybe within a week after that, it'll be here, and we'll have a brand new range with 2 ovens that'll work really good for us.
And that'll be electric or propane?
It's electric. We don't have any gas in the kitchen at all. And it's not the same one that we got. The one that we have now, I haven't been real happy with its performance. So we got a different brand, convection ovens. It should work really well for us for the amount of food that we're putting out. But you are gonna probably hear me a broken record with this, and I'm sure it's not something new for you to hear, but our kitchen is in dire need of a remodel. It's been put in the budget every year. I just don't know where the money's gonna come from. So I keep hearing all these other departments talking about grant money. Is there any way to get grant money to build a new kitchen? I don't know what a solution is, but it is run down. We've got walls that need repaired. The floor needs repaired. It's as old as this building is. Yeah.
Is it mostly maintenance, repair, or is it reconfiguration?
There's a little bit of reconfiguration. When Charlie first came here, he brought an architect down to come and give us a design plan. I think that would probably need to be redone with a new price on what it would cost. That's probably been close to 10 years ago now. Yeah. But every year it just gets a little worse and worse. And I keep my staff keeps asking me about it too, and I say, hey, it's in the budget. I keep trying. I just don't know where the money's gonna come from, because it's gonna be a big cost, which I'm sure you're aware of. I think we were quoted maybe 350,000 back then.
It'll be $500,000.
Yeah.
Chump change, we'll find it somewhere.
So, you know,
Say that again, please.
But
anything you need to know from me? Any questions?
no,
Thank you.
much appreciation for what you guys do.
Thank you.
EMS?
Things are good in EMS. We had a pretty steady January, and we've already started off February with almost as many transfers as we did last month, so things are good.
Okay, anything else?
Heidi, do you want to say anything?
Well, I didn't know if you wanted me to jump in or wait. I didn't know if you had planned on bringing anything up with mental health and the burn grant, so I was just kind of going to follow your lead there. If
Okay, well,
you want me to jump in, I will, otherwise.
Please do.
Okay.
because this is department reports and it was just a blank here, so I just started shooting everybody.
Going down the line. Well, in mental health, we've had a bit of a challenging year. I just completed my first year as executive director, and for the majority of that time, I have been basically it. I have not had a mental health clinical supervisor, nor have I had an SUD supervisor. So it's been tough, but we've gotten through really well. I did just hire an SUD supervisor this week, and so she got started, and that has been a tremendous relief for me. I'm still doing a lot of things with her because I'm wanting to make her transition pretty smooth. I don't like it when we hire someone and just like dump them in and say figure it out. So I'm still doing a lot of the responsibilities alongside her, but I'll be able to start pulling back from some of those responsibilities, which will be nice. I also have a lead on a potential behavioral health or mental health supervisor, and hopefully we'll be getting an offer letter out to her pretty soon, and then if she can take that position, then same thing. She'll start taking over a lot of the clinical responsibilities, freeing me up to do more of the director job that I need to be doing and continually learning more about. One of the other things, though, that has really come about through this last year is we received a burn grant, Behavioral Health Regional Network grant, and with that, our plan is to purchase and refurbish and open a drop-in center to better provide services to individuals who have substance use and mental health issues, and to lessen the barriers for people to get that help. We want to have more open doors, and so a drop-in center we decided is a really good way to do that. Now, we did receive the grant funding. We've been looking around town, trying to find a building that we can purchase or rent or lease or whatever we're going to do. Mostly we're talking about purchase because, as we all know, most of the buildings in this town need some kind of work and renovation, and so we would want to have ownership of that building if we're going to put that much of an investment into it. So we are trying to to focus in on a location. In the meantime, in working with Charlie, we had decided to use the apartment that is at the corner of the Wellness Center, right behind Animal House. And so we've opened that up as what we're calling a temporary drop-in center until we get our nice big location wherever that's going to be. And so right now we're just keeping it open 11 to 5 Monday through Friday. We've already had a couple people drop in, and one did result in seeking services. And we've just only been doing this a few days, so I think that bodes pretty well. So we're using that as a location where people can come in, they can socialize, they can participate in skills building, they can meet with peer supports, and then again have help getting access to treatment providers. We've started doing some skills building there. When we get to the bigger location, one of the things that we're hoping to expand into is to have a small, kind of what I'm referring to as a computer lab, so that individuals can come in and have help to learn how to use the computer, how to apply for jobs on the computer. We can use the computer to get food handlers permits, so we can help people get prepared for employment, and just, general education. And then again, like I say, we'll continue to have support as they look for a job. We're going to have basically a job coach that can help them find jobs, help them get started in jobs. In the apartment right now, we do have a shower so that people can get clean, because that is a need for a lot of our folks. We've been collecting clothes, we've been taking donations so that we can have people put on clean clothes when they get out of the shower, and also have some clothing that's a little more business-like, so when they do go for a job interview, they'll have the appropriate clothes. Eventually, in a fully scaled drop-in center, we're also going to include laundry services, is one of the things we talked about, because again, a lot of our folks either don't have running water or don't have a way to get their clothes clean. So that's kind of what's going on in the world of mental health. We got a lot going on. I'm really excited. I'm so happy that we even have just a small drop-in center, and I'm just really looking forward to getting something much larger so that we can really expand the services.
Outstanding.
Yeah. Got a little question about clothing. First I heard about it. Do you have a storage area that you have an array of sizes, gender, everything like that?
Yes, in the apartment. The apartment was a 2-bedroom apartment.
Yeah.
In the first bedroom, we're using that as the office for our certified recovery mentors, and in that bedroom, one entire wall is closet space with drawers and cupboards up above. And so we have designated, we have a men's closet and a women's closet, and they are organizing them by size so we can have those things. And then in the second bedroom, we actually took the wall down between that room and what was kind of like the dining room area, and that's our group room, our skills training. And then we do have a kitchen where we can work on skills training, we can work on food preparation, we're going to have nutrition skills groups. And then it does have a fairly nice backyard. It's been covered in snow and frozen for quite some time, but I'm hoping by spring and summer that'll also be a place where people can go out and congregate and probably smoke and things like that. But it'll keep them off the front street. Yeah. We'll put some picnic tables and stuff back there. So we're really excited about the space that we have.
Thanks. I need to clean out some of my closets, is the reason I asked about them.
Bring them on down.
Kim, did you want to say something?
Sure. An update for cardiopulmonary services, which includes the sleep lab. Did you just now recognize me? Is that what? The sleep lab, we are still plodding away with our reaccreditation, and we came to a little bit of a challenge with follow-up on our sleep patients, because the AASM requires that we offer services for a sleep physician. So we're going to be working with our sleep director, Dr. Bauerfeind, to implement some telehealth options for our patients for those who want that, which will also go in line with the pulmonologist telehealth with St. Charles, if that re-energizes itself. We've kind of been ghosted a little bit by St. Charles, so I'm not sure where they're at with the pulmonology section of that. But our sleep lab is doing well, and we continue to get a constant stream of patients coming through. A lot of our patients for the sleep lab are coming from Alturas and the area down there. So Teresa and I went down to Modoc Medical Center and did a little bit of luncheon marketing meeting, and it went very well. They're super excited to partner with us to take care of the patients in our kind of joint patient area. And we have opportunities to partner with them for like our Zeo patch, our cardiac monitors. They were interested in possible stress testing, certainly expanding their referrals for radiology and the like. So it went very well. our referral management help with Mauricio that was in Arcturus, and, you know, working with Lisa and the referral staff has been great, because they already have a working relationship with the clinics down there, Canby Clinic and Pitt River and things like that. So we're gonna be doing some more marketing to kind of just let everybody know what we do and that we're here to help serve the patient population. Cardiac rehab and pulmonary rehab, we've graduated several patients, so we have several more in the queue that are just waiting for pre-authorization, and we'll get them started. I'm hoping to partner with some of the community groups with like Silver Sneakers and the gym, so that we can, once we graduate these patients, we can help excuse me, integrate them back into other lifestyle events and things like that, opportunities like the walking clubs or the gym or something like that. So just working on providing consistent service, and we had a Cerner rebuild project for the cardiopulmonary department, and it went very well. So I think on the charge side of things, we were able to connect a few dots and kind of fine tune things on that end. So I'm pretty happy about that. Our documentation is much better. The follow through is much better on the billing side. So pretty happy about that.
Excellent.
Yeah.
Thank you. Thank you.
Quentin? Yeah, I can talk to a couple of issues. As you saw, the DME is doing very well. We're very proud of the services they're providing, and so that's always a solid area. For environmental services, we're pleased that we were able to add 6 staff in January, and we haven't lost anybody during that period of time. So I mean, that's a big win. Now the challenge is just get them all well trained, and so we're in the process of making sure that that's happening. And when you leave, you'll probably see several of them out doing floor work and other cleaning this evening. As for supply chain, I think probably one of the bigger things we'll be working on next is the transition for pharmacy distribution, working with Teresa Decker and Charlie to make sure that that goes smoothly. Our group purchasing organization has an agreement with Cardinal for pharmacy distribution that should yield us some savings. The distribution fees are much better than what we've experienced with our current agreement with AmerisourceBergen. And so I think there's an estimate out there about $40,000 annual savings for pharmacy distribution. And so that's a big challenge. It's going to be a lot of work for Teresa's team, and so we'll be working with the vendor Cardinal to make sure that they're supporting us as best they can, both remotely and on site as much as they can provide. So that'll be a big one. And then I'm also just working with all the different leaders to try to make sure that as they project capital purchases coming up, that we're getting quotes and having everything prepared for their requests.
Questions? Thank you, Quentin.
Thank you.
Okay, did I miss anybody else? Okay. With that, department reports, we go to CEO report.
I will be very brief because everybody.
They stole your thunder, and that's good.
When we talk about the grants that we have, we've received $4,132,000 in grants. It's a lot of money. So trying to figure out how we can spend. A lot of this is very, very specific on what we can spend. So it's hard, and especially when we have so many departments that have so many needs. As Stephen says, oh yeah, we've got that a big expense in radiology because of the fact that our building now is, the new building is 12 years old. We're going to have to replace lots and lots of things because end of life occurs for equipment in the 10+ year time period. And as we look at that, Ortera has been struggling with part of the old infrastructure from the original hospital built in the 70s,
Right.
let alone the equipment that we've got to replace. We are, I think I told you before, that the geothermal repair, since we have not been able to work our geothermal system, it's been clogged, and then it damaged the heat exchangers. The repair is $47,000. And they're going to try and start that next week. It took us a long time to find a company. And what they're recommending is to keep the heat on, we have to change the heat exchanger, and that's $150,000. And we need to do that in the next year or so. In radiology, just changing the X-ray room is $750,000. So what we need to do is have each of the revenue generating departments double their volume. And then maybe we can, maybe we will find the funds to do that. But we will keep persevering and finding ways to do this. As several of you know, Dr. Mark Bradbury was the Medical Professional of the Year for the Chamber Gala, so that was a nice thing for him. We are continue to work with OHSU to bring, we already have residents from the Oregon OHSU residency program in Klamath Falls. We get 2 residents a year that come here. They spend their time predominantly with Dr. Grant. We're seeing if we can maybe shift that so we have a combination of both locations. But we're working with OHSU in Portland to have mid-levels that are students. So that includes nurse practitioners, includes physician assistants, and midwives. So we've been working to have that. It looks like we'll be able to get that in this spring. We think OHSU was trying to get their schedules to work. And they require that they are here during the time that Dr. Tan is here, because that's a big part of the training that they need. And she's very interested in helping with that training. You probably have heard, but let me refresh. A couple nights ago, the Lapine Clinic announced that they were going to leave the Northwood Health District in the end of April. My phone has been ringing off the hook with people asking if we are going to consider it. And so what I hope to do is gather enough information to help you decide if that is in our health district's best interest.
Haven't we been asked?
Yes. I don't have a letter from the health district stating that, but I have from people that are asking. So I'm not saying that that's something we should do, but that's something that we have to look at. Just like as Tyson deals with the other volunteer ambulance service areas that are staffed with all volunteers. Sometimes they have enough people, sometimes they don't. And while we have staffed, employed people, many places don't. So we have to keep looking at, is that in our best interest? It may be in other people's best interest, but we have to work on that.
It's one thing to provide the service, it's also the other to be able to afford to provide the service. So those are-
We have plenty of cash needs here.
So you have to keep ahead of that water first.
Yeah.
That's right.
But reach out and investigate, come back to us.
We'll be working. We normally have a strategic planning meeting at least twice a year. We're due for one. I'd like you to look at your calendar in March. Possible dates are the 7th, the 13th, 14th, or the 20th and 21st. So if you can let Lauren know or let me know when you have a chance.
What's the date?
Pardon me? So the dates are March 7th, so we'd like to try and get that done in March.
Well, that'll help your budget planning and all of that too.
Oh, absolutely,
Yeah. So
absolutely.
it would just have to happen to be right in the middle of tax season, but I'll make the room any day.
So would you rather wait till April 17th?
No.
Or is it April 18th this year?
You know, it doesn't really matter. No, March anytime for me is fine. I'll make it happen.
My March is pretty much open at this time.
Gerald's the busy one.
He's not going to Alaska or to Hawaii
Oh.
in March?
Both?
Okay.
I thought you were taking a trip down the Amazon.
Okay.
Do any of you have any questions on any issues that we can address? I think you've heard plenty.
Yep.
Great. Enjoyed that.
Good. Very good. I appreciate all
Thank
of
you.
the people coming in today. It's been excellent. And hearing some positive things coming out is real heartwarming for me. We just need more money. So we'll get after it. We'll get into executive session now under ORS 192-660, Dr. Drew Bradley.
Quick question for you, Tom.
Medical.